Okay, today I'm going to show you how to put an NG tube in. Alright, so we're going to be following our checklist. Now remember, we learned a lot about this last semester. We didn't learn how to put it in, but we learned a lot about our tubes. Remember, when we put an NG in, nasogastric, we're talking something is going from our nose to our stomach. Our nose to our stomach. So we're either putting something in, like tube feeding, or medicines, or we're taking something out, like stomach contents. We're trying to let the bowel rest. So depending on what you're doing as to what kind of tube you may need. Remember, you're not putting stuff in and taking stuff out. You're usually doing one or the other. I wouldn't be feeding them with a tube and then stopping and suctioning them. That doesn't really make sense, does it? So usually I may be suctioning them because they have, for example, a small bowel obstruction and I'm trying to let the stomach rest. Or they came back from surgery, or they have to go to surgery and don't want the stomach contents to be building up. You know, your stomach is constantly making secretions and stuff. So I wouldn't want that to, I want to let it rest. So I'm putting stuff in, or I'm taking stuff out. So remember, this is a dop-off. This is that small one, the small bore. And then I have a Salem sump. So with the Salem sump and a dop-off. So which one am I going to decide to use? This is very tiny. This person Mr. Jones has a small bowel obstruction. So he has an order for an NG to low intermittent suction. So if I need to suction stuff out, would I want to use this tiny little, really flexible tube to suction stuff out? And it's really tiny. So do you think I want to use that? If I do that and I'm constantly suctioning, what's this going to do? It's going to collapse on itself. So I want a little bit more thicker tube, the Salem sump tube, to actually suction out. It's harder. It's not going to collapse on itself. Yes, it's not quite as comfortable because it's harder. So, I have to think about that, but at the same time, that's what I need to get the job done. So I look and see, so I'm going to say a Salem sump, and I think about what size I need. There are different sizes. There's 12, there's 14, there's 16, depending on the size of the patient really as to what I would choose. So like a little kid, I might, choose a 10, adult, maybe 14. The 14 is larger than a 12, 12 is larger than a 10. It goes just like what you would think it is when it's French. So I'm going to pick this Salem sump 12 French, and you have to kind of make sure that you know what that is because you're going to have to write that down when you document. So I've determined why the tube is being placed. Now I have to gather my equipment. So what do I think I need to gather? I'll probably want to put a towel down because it can get messy. I'll definitely need gloves. I'll probably want to bring a basin, maybe this little emesis basin or maybe even a bigger one because they can, it's not fun and it could stimulate their gag reflex and they could have some emesis. So I'll bring an emesis basin. I'll want some tape, all right. I probably will go ahead and bring a catheter plug because if I have to get it x-rayed and all that, or even just when I'm manipulating, it's easier to use that little plug that you have at the end. When you look at the Salem sump, it has an opening at the end, but I want something that's going to be able to close at the end, so I'm going to bring a catheter plug so that I can close it while it's not hooked to suction. So I'm going to bring a catheter plug. I may even bring an anti-reflux valve if my Salem sump doesn't have it on there. Maybe. I definitely need to be able to manipulate and work with this, so I'm going to bring a little piston syringe, the piston type syringe, the kind that you use with your little irrigation tray. And if it's time to irrigate, I probably bring some saline. For irrigation for suction, we usually use saline. When we're giving tube feeding, we usually use water. So I'm going to use some sterile saline. When I get it down, I'm going to need to look at the contents, and I'm also going to do a check to see if it's in the right place. I'm going to bring some pH strips. So I might bring a little medicine cup and get my pH strip in there. It's easier for me to manipulate. But I will need the container because I need to see what that pH strip, once I test it, what it actually reads. So I'll need that. I'm going to do some assessments. So I'll need my stethoscope. I will need my pen light. I will need, gosh, I can't even think of what these are called. You know what I'm talking about. What are these? Isn't that terrible? When I secure it, I'm going to need some tape, and I might need a rubber band and a safety pin. I might want to document how much is left out on the tube, so maybe a ruler. Okay, and then I think I have everything I need. I'm also going to make sure I have my suction equipment. So a lot of times it's on the wall, you have to bring in the actual container itself and hook that up. Sometimes there's a liner and you hook it up and you might need to bring in the actual tubing. So a lot of times it comes like this in a package and you take your tubing and you hook that to the suction and have that ready to go as well. So I'll have my suction. So I'll make sure if I don't have one on the wall, I have a bedside one, and then make sure I have my tubing and the insert that goes into the suction container. Of course, I'm going to need gloves. So I come in the room, I decided that I don't need the dock off, I need just the Salem sump. I come in the room, I introduce myself. Hi, my name's Debbie, I'm going to be your nurse today. Can you please tell me your name and your date of birth? And he does. And I'm going to identify the patient and explain what I'm going to do. So I have this this NG tube we're going to put down, it's into your nose, it's going to go into your stomach. I understand you're having some trouble feeling nauseous and feeling uncomfortable. I understand your abdomen's distended. You have a small bowel obstruction. Well, this tube, it's not going to be, truthfully, it's not going to be comfortable when it goes down, but we'll get through that together. I will help you with that. And once we get there, that tube is going to release that distension you have on your stomach. It's going to help you to feel a lot better in the long run because it's going to relieve a lot of that nausea you're having. All right? He shakes his head yes, and he tells me he's ready to do it. So, sir, now I need to do some assessments. So first of all, I want to assess his nair. I want to put it down. Now this sounds counterintuitive, I know. I want to put it down the nair, the nostril that is most patent. And I hear people say, well, they can't breathe that way. Sure, they can still breathe. But the reason why I want to put it down the most patent nostril is, let's say you have a deviated septum. Let's say you have polyps or something, and I try and stick this big tube, this 12-French tube, through this deviated septum or past this polyp, but past an area that can't breathe real well. Well, I'm probably going to irritate something. I'm probably going to cause some bleeding or something. So I want to put it down there that is the easiest to get down. They can breathe around it. They can still breathe through their other nose. They can breathe through their mouth. But I can't stick it down something that's really going to be really difficult to get down because I'm going to cause trauma. So I want to go down the most patent. So I'm going to go ahead and check his nose out. I may need to even look inside. So just let me take a look inside. Do you have one side that you breathe better out? I'm not sure, he says. So I can take my finger on my nose and have him breathe out one side and then breathe out the other. Yeah, I think I breathe better out my right. Well, sir, I'm going to use that nair to actually put it down here. It's going to be easier to insert. It will be less uncomfortable for you. He shakes his head, yes, he's ready for that. Then I'm probably going to go ahead and take a look inside of his mouth. Sir, can you go ahead and take a look at it? I want to make sure that it's free of obstructions. I may even check a gag reflex back there. And I'm checking because I want to know how difficult is it going to be for me to put this down. Is he going to gag a lot? Now, if he's really nauseous and gagging all the time, I'm probably going to skip that gag reflex because I don't want him to throw up all over me. But, if I'm not certain, maybe he doesn't have a good gag reflex, and I'm going to have to be really, really cautious when I put this down so it doesn't go into his airway because I don't know, he's not gagging. I'm not sure what's going on. Somebody who's kind of out of it. So I may do that. Again, use your judgment. All right, but I do definitely want to take a look down there, make sure nothing is no obstructions and all. And I'm not just going to observe his nose and his mouth though. I do want to do a full assessment on him, especially if I'm doing, what's the order for? It's an NG to low intermittent suction because he has a small bowel obstruction. I want to take a look at that abdomen, see where we are with that. What do I kind of expect? I kind of expect it may be large. So I want to get a good base so I can compare my intervention to see, when I evaluate, to see if that intervention was successful, to see if it is less distended, if he's less nauseous. So I start, when we do an abdominal assessment, we have him back a little bit, I'm looking, does he have distension? Is it flat? Is it distended? His is probably distended with a small bowel obstruction. Then I'm going to look first, then I listen, and I may not hear bowel sounds, or maybe I hear a real high tinkly type bowel sounds, which you may hear with a small bowel obstruction, or like I said, maybe none at all. So I listen, and then I may palpate gently. We're not going to dig into this man. Gently, it may be tender, it may be firm, okay? So I got a good baseline assessment for him. All right, so I've got that. What's the next thing it says on here? It says to wash your hands and put on gloves. So hopefully you washed your hands when you walked into the room. You always do that, remember? But if I may need to wash my hands again, that's fine. And I'm not going to put my gloves on just yet. I might make sure I got everything settled and ready to go first. But I'm not gonna open my packages up until I get my gloves on. Because you know, it's kind of like, the gloves are to protect you, but it's still, it's kind of a, even if it's not a psychological thing, I wouldn't want you touching my stuff that's going down my mouth with your bare hands. So I'm gonna wait to open up any packages until I get my gloves on. And then I'm gonna go ahead and open my packages up. And I'm gonna use my catheter plug. When you open up the Salem sump, you're gonna see that when you take it out of the package, it looks like this. It's going to have an opening at this end and an opening at that end. This is the part that connects to the suction. I'm gonna go ahead and take that out right now, and I'm gonna, so I don't lose it because it gets lost easy, I'm gonna go ahead and connect it to my suction tubing. That way it's ready to go. All right, so it's connected to my suction. Now remember we talked about this in fundamentals. When you have an NG tube, a Salem sump, it's got two lumens that kind of come down together and they both come out. Now this here is where you actually connect it to suction. This blue one is an air vent. This is, the air vent again, remember is, so let's say if I'm just constantly having something sucking against my stomach wall. If I just had that, it's kind of like, you know, a hickey's going to be formed kind of. It's going to cause trauma, basically. This is an air vent so that you don't have such strong suction. Yeah, granted, I'm going to be on intermittent suction, but this still helps, this air vent. Now, this anti-reflux valve, if it doesn't have it, I'm not going to make you guys put this on, but you notice the blue? It goes to the blue. It lets air go in. I'll show it to you real quick. It lets air go in one way. This way, but material can't be sucked out. So air is able to come in and help with the air, but you can't have fluid being sucked out of this container. We don't use this except for air, so you really shouldn't have anything in that line except for air. There shouldn't be any suction material, there shouldn't be any food, water, saline, any of that. This is just for air to help relieve some of that potential for it to suck up against the wall. So whether you put this one on or not, I don't care, check out. But here, when I put this in, I'm going to, just like when we did for tube feeding, I'm going to want this to be closed. That's where I'm going to take my plug and put this as a kind of a cap. This is closed on the inside, so it's a cap so that I can manipulate it without it spilling all over the place. Especially if I'm going to send them down for x-ray, I don't want it pouring all over the place. Because sometimes when your abdomen's distended and you may have a little bit kind of coming up, but also when we're doing our testing, we have some of that suction material in the tubing, all that. So we don't want that, so we're going to put a cap on it. All right, so I've got my tubing and all that. All right, so I've got my material ready. It's all ready here, 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 here. I'm gonna go ahead, and I think I forgot to tell you, I'm gonna retort. I wanted to, when my gloves were off, I wanted to tear my material. So I would tear a piece of tape, and then I'm gonna tear that piece of tape lengthwise in half, so it kind of split like this. And you can do that with your gloves are off. I forgot to do that. And then I'm gonna have a tiny little piece of tape that I'm gonna use for measuring. And maybe another piece that goes across the bridge of the nose. So let me take a little piece for measuring. This is a big tube. Now, I don't know how far I need to put it down. Everybody's a little different. We're all made differently, right? So I need to measure to know how far it goes down. So before I stick it down, I want to measure. So how do I measure? I want to go from the very tip of this tube. I put the tip of this tube to their nose, then to their ear, and then down to their xiphoid process. Remember the xiphoid process when you went to a CPR class and they told you that little thing sticking down there? That's the xiphoid process. So that is where you want to measure it. And that actually comes out to the right length where most people, if you measure on that person, that should go down to their stomach, from their nose to their stomach. So I'm going to take a piece of tape, or you could use a marker, and mark that spot where it measured. Because that is where I want to stop putting the tube down. And that's how far I want to go. Okay? You can use a marker for this, or you can use, now there's all kinds of measurements on here. You could use that measurement and stuff, but it's better to have a marker or a piece of tape, which I will make you do and check out, so that you know how far you're going down, because sometimes we start going and we lose track of what was the number and all that. We want to make sure that we know that, because that's an important thing. Now, I highly advise you to stop right here at this point before you actually start on that patient and make sure you have everything that you need done. Is it all done? I mean, if you don't, you can sit this right back down on this container. You know, you're open and set it down and look and see. Do I have everything done? I do. I think I have everything. I got my syringe, I got my emesis basin, I got my cup of water that they're going to need. I've done all my assessments. I've measured. I think I'm good to go. So now I'm going to go ahead and open up my lube. Open up your lube package. You want to lube this tube about 3-4 inches. I'm going to go ahead and lube the tube, sir. And I'm going to go down that nostril that was more patent. And I know it's going to be hard for you to, it's going to be uncomfortable. It's going to be hard for you to tell me to stop and all when I'm sticking it down your nose. So we'll have a little communication system. If you need me to stop and you need me to take it slow or something, just raise your hand for me and I'll see that hand and I'll stop. Okay, so what I'm going to have you do is first we're going to start out and I'm going to have you bend your head slightly back. I'm going to have you flex it back. Now I'm not talking hyperextended, guys. I'm talking about he wants to bend his head slightly back onto that pillow. And that's going to be, because his head's back, I'm going to be trying to angle around the nose and down. I'm not shoving it up into his brain, all right? So I'm trying to angle it back the way the nose goes. So I'm going to go in and kind of down. Once you feel like a little gag, once I get down there, it'll hit the back of your throat. You'll kind of feel that. You may even gag. I'm going to have a general idea of how far that is, all right? All right, I have a general idea. Once I know I got to that area, then I might even take a look and see if I'm there. So once we get there, then sir, what I'm going to have you do is I'm going to have you take your chin to your chest, and I'm going to give you a cup of water, and I'm going to take little sips of water, okay? So speaking of chin to the chest, why do I do that? When you put your chin to your chest, it closes off your airway. Also, when you take a sip of water, it closes off your airway. Try and drink, hopefully, try and drink and breathe. You can, right? So when you drink, you don't get a bunch of water in your lungs most of the time. And so that's the same purpose. When you're drinking, your airway's closed. Now, can I always give them water? Now, I want you to think about it. Usually they're NPO. Now, you can get this clarified from the doctor before you put it in. But a lot of times we can give them sips of water if you're putting it down because they have a small bowel obstruction or nauseous or something, because we're going to be sucking it right back out. But if you have somebody who is aspirating, it's going into their lungs every single time you give them a sip of water. Would that be a good idea to give them water? No, because they're aspirating. We're trying to avoid them for aspirating. So it depends on why you're putting the tube down. So if you're doing it for like tube feeding and it's because they're aspirating or something, well, probably no. But if you're doing it because they have like you just need to rest their bowels and you're putting it down, well, maybe yeah, okay? So I got everything ready and I'm going to go ahead and start inserting my tube. Sir, can you go ahead and put your head slightly back for me, and I'm going to go ahead and insert. So I'm angling it back. I've reached the back of his throat. He kind of gags. I may even look to see. All right, sir, can you please put your chin to your chest? And I'm going to give you this cup of water. He holds it. All right. When you take a deep breath, when you drink, I'm going to advance it. I'm going to advance it one little gulp at a time. So when he gulps, when you take a drink, sir, I'm going to, if they can't drink, you can have them dry swallow. All right. So when you gulp, your chin is to your chest, gulp, advance. Chin is to the chest, gulp, gulp. If you meet resistance, please do not shove. You can take a little twist and it helps it go down, okay? Gulp, 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 gulp. Do you notice I'm standing on the side of the nair that's most patent? Gulp, gulp. My mannequin doesn't really go down all the way. Gulp, gulp, gulp. If he were to stop to breathe, I stop. I don't advance when he's breathing. So I'm going to go ahead and take this out now. I'm going to go ahead and temporarily secure it at this point. So I'm going to take my torn piece of tape, and I'm going to put the piece that wasn't torn up on the top, and I'm going to put another piece right over here. Then I'm going to secure it, making sure you're not resting it up against the nose and causing any sores. I'm going to go ahead and secure it by taking one piece and wrapping it around here. Sometimes they make little secure things that you can put on the nose that are actually here, but if you have to just use tape, you just do it this way. Now that's temporarily secured until I can do some kind of assessments to see if it's in place. All right. So how do we check when we do our tube feeding? We put air in, and we, not to listen, but we put air in to move it against the away from the stomach wall. Well, it's probably not against the stomach wall since I just put it in, so I don't need to put the air in. But at this point, what else did we do when we checked it for tube feeding for food? We pulled it out, we looked at the color, and we checked the pH, right? We're going to do the same thing here. We're just not don't need to necessarily do the air because it's not against the stomach wall, it just went in. So I'm going to take my piston syringe and I'm going to hook this up to my NG tube. I usually have to crimp it first, remember, so that I don't get any stuff that could be in the tube. So I take the cap off, set the cap down, hook this back up to the piston syringe, and I pull a little bit of stomach contents out. And I look at what the color of it is. What should it be? Like a grassy green? You may see different colors because why will you put it in depending on what you're putting it in? So maybe they had a old GI bleed. So maybe I'll see coffee colored emesis. So just different reasons you may see different colors, but usually like a grassy green in the stomach. And then I'm going to check the pH. Remember, I went ahead and prepared my cup ahead of time. So I'm going to go ahead and crimp this off because I don't want this stuff leaking all over me. I've got my towel down. Take this off, put this down, put my cap on, and squirt this into on my pH paper. Okay, and read my pH strip. What does it say? What do I want it to say? Well, what is your stomach contents normally? What they tell you in anatomy? 2, 3, below, because it's acidic. What do we say? What's your book say? 5.5 and below? Because you could have some kind of medicines like Zantac, all those medicines that could lower your pH, or maybe there's food in there that lowers your pH. So 5.5 and below. Typically it's going to be lighter. It's going to be lower than that. So let's say it might typically read 4 or below. So I look to see if it's in the stomach. Now, if I know my tube is secure, I can go ahead and put my piece of tape on. So I have one that goes one way, and I'm going to cross it over and go the other way with the other piece of tape. Okay. Oops, I just messed up there. And I might put another piece don't look too careful at that one. I nearly messed it up here across the bridge. Okay. My tape tore funny, so I'm going to refix this a little bit better. Again, making sure that it's not pushing on the nostril. And then I would want to secure, if I was not sending this to X-ray, I would go ahead at this point and flush it with some saline. Flush it with some saline. Oops, about 30 of saline. Now this is not sterile gloves, they're just clean gloves. And flush it with some saline. And what does my order say? My order says to hook it up to suction. So I want to secure it to their gown. Sir, can you turn your head this direction? I'm going to have him turn his head this way because I don't want to pull too tightly. Put the piece of tape, put the rubber band on. So make a little circle with your rubber band. And then keep your head turned that way for a second. I'm going to go ahead and secure it. And then I'm going to take my cap off, crimp this, take my cap off, reach over and use my extension tubing and connect it here like this. Turn it to low intermittent suction. Now, sometimes if you're putting a tube in, as soon as you put that tube in, instead of connecting it to low intermittent suction, they don't let you use it until you have an x-ray. So, let's say I just got my stuff out, I've just gotten my pH, it's bore, I've looked at the color. At that point, one other thing I forgot to show you. At that point, I would go ahead and connect it up and send them down to x-ray, okay? To be able to make sure it's in place, because that's your most accurate placement is to check x-ray. So at that point, I wouldn't necessarily flush it with saline until I got an x-ray on that. It's okay that there's a little bit in the tubing, you know, it's okay, because remember, there's stuff in the tubing all the time if you have it to suction, because there's usually stuff in there. So then I would take it to x-ray. And then I also, another thing that I would want to do once I got this tube in place is I may, depending on your facility, I may measure where it comes out at the nostril to the end, without the cap on, to the end of here. Hold it straight out and get a measurement in centimeters. This to this is how many centimeters long, because that becomes another check for you when you go to check to see if it's in place. All right, so I go from here to here. Now, why in the world did I flush that with saline? Remember, you guys, I said that I'm putting it to suction, so I want to bring stuff out. Well, we still need to flush with saline, usually like with 30 cc's of saline every 4 hours or so. It's just to keep that patent, because sometimes you have stuff coming out of here that's not always the thinnest. You know, we used a big tube. We didn't use that dop-off one that would collapse on itself and hardly get anything out. But sometimes we still want to make sure it's patent, because he did not enjoy having this put in. So I want to prevent it from getting gunk stuck in there. So I would, every 4 hours I come in, I need to check placement, just like you guys did when you did your tube feeding. Put a little air on there to move it against the wall. You're not listening at that point, you just put a little air in. You pull up your contents. What's it look like? Does it look like stomach contents? Check the pH. Once you know that pH is fine, once you've done, and you can even do the measurement, just like you guys did with tube feeding, because before you put anything in, you must check placement. So I would check the placement, and then I could irrigate it. I can irrigate it, slowly irrigate with 30. Don't be pushing too hard. Slowly irrigate it to keep it patent with saline. Unhook it, crimp it, unhook it. Don't pick it up off the ground. And connect it back to low intermittent suction. All right? So you want to be documenting what's coming out. You want to be documenting all of that, okay? So I've just put this in. Let's say I put this in and I didn't have to get an x-ray and I hooked him up to suction. So what would I document? I would need to document that I inserted a what? A 12 French Salem sump NG into the right nair and how the patient tolerated it. I might want to document how much was left on the outside, so that measurement that I took, all right? I also would want to document that I hooked it up to low intermittent suction as ordered, and what came out. Immediately within the first 5 minutes, output was blah, 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 and what it looked like, with the color and the consistency of it. And remember all that coca stuff, anything that you document. If I irrigated it, I would be, and also I'm going to make it a chart of whatever irrigation, how much I irrigated it with, how much output is out. So I'm going to have an I&O flow sheet on this too. All right, and what my pH, all that was. Hope you understand that. Wash hands, let's see, apply this to suction, wash hands, discard supplies, and document procedure. Take that off, make sure he's comfortable, all that. no.